So here we are in the lab. What I'm going to do now is just run through practically how we restore the contact point, the class 2 box, with direct resin. Now you may recall that I mentioned earlier about using resin modified glass ionomer in the gingival half. Now that is an option, but for me it's not an option I ever personally do, and the reason for that is typically resin modified glass ionomer does not give you quite as good aesthetics. It's a little bit more opaque generally, and it's a little bit more grainy. It doesn't polish quite so well. The other reason why I personally don't use it is because its mechanical properties are not as good as direct resin. However, if you want to use resin modified glass ionomer, it's fine, but you need to appreciate that there are some compromises there. The reason why we use heated composite resin in the gingival half is because by heating, it reduces the viscosity and improves the adaptation. So what I have here is some heated direct composite. I'm taking that to the cavity, I'm placing that, and you can see the viscosity is way lower because it's heated. In other words, it flows more. Now, most people would condense that using a metal instrument. I personally don't condense it with a metal instrument. I tend to use a microbrush. Just condense it like so. Because it's heated, it condenses and adapts really nicely. Now, the reason why I adapt with a microbrush is firstly, as you can see, it doesn't bond to the microbrush at all. Try as I might, I can't get it to pull back here, which is a good thing, because if I don't get any pullback, I get good adaptation and no voids. The other advantage is that because the microbrush is a little bit bendy, like so, if I put a lot of pressure on with the microbrush, I cannot force the composite resin between the wedge and the matrix because the brush just bends. If I was using a metal instrument, I would be able to push really hard and force that material between the wedge and the matrix and therefore end up with an overhang. So it's kind of like a fail-safe. So what I've done is I've adapted that gingival half to the same level as the isthmus here. Now what you've got to remember is if I just light cure that to full polymerization now, I'm going to get a large amount of polymerization shrinkage, quite a lot of stress, and I'm probably going to end up with a marginal gap at the gingival, and I'm probably going to end up with sensitivity. So if I use this approach, I'm just going to give it a light cure with what we call pulse activation. What we're doing here is we're just light curing not for 10 or 20 seconds, but initially just for 1 to 3 seconds. And what that does is it initiates the polymerization reaction. So the composite has started to polymerize, and even when I take the light out of it, it's continuing to polymerize, but at a much slower rate. I then leave that alone for a period of 2 to 3 minutes. Obviously, I don't just do nothing for 2 or 3 minutes. I might go and work on another tooth if I'm doing quadrant dentistry. If I'm just doing the one tooth, I may take my gloves off and just write my notes, write my records. Once I've done that, I come back 2 to 3 minutes later and give it the full light cure for 10 to 20 seconds. I've then restored the gingival half of that cavity. We're then ready to move on to the occlusal part of the restoration. So another option for restoring the gingival half is to use a flowable bulk fill. The advantage of using a flowable bulk fill is because of the chemistry, it generates a lot less stress if you fully polymerize it. So because of that, you can avoid doing the pulse activation. So let's have a look at that on the model. So here I'm using SDR from Dentsply. I like this because it has a very long nozzle, which is helpful, particularly in difficult to access areas. I'm taking it to the tooth, I'm pushing it right into the box, and as I inject the composite resin, I'm moving it from side to side, but I'm keeping the tip of the compule in the resin. If you lift the tip of the compule out of the resin, you'll end up getting lots of little air blows. And I'm filling until the depth of the box or the height of the box is the same as the isthmus. Then, once I've done that, I usually use an explorer, something like this, straight explorer. And you can just use that. This is pretty well adapted, but if you have any defects, particularly palatally or buccally, you can adapt with the explorer. It's very rare, but if you have any air blows, you can just use the tip of the explorer just to pop those air blows. And then once you've got that in position, you can simply light cure for 20 seconds and you're good to go. Once we've restored the gingival half with either bulk fill composite resin or regular composite resin that's heated, we're now ready to restore the occlusal half. The way I do this is by taking the composite resin directly from the gun, the compule, taking it to the tooth, injecting it in the center of the tooth here, like so. Then we go to the microbrush, and what I'm doing with the microbrush is just pushing that into position, like so. And what we're looking to do is to make this as thin as possible. We're looking for about 1 millimeter of thickness here, so very, very thin. The reason why we want to have it thin is because the stress the composite resin will generate as it polymerizes is volumetric. In other words, it's related to the volume of material. So the more volume of material there is, the more stress it will generate. So I'm only using a small amount of material. So I've roughly got that in position there. Now you'll notice it's not that well adapted here or here. So my next move is to take a probe, an explorer. You can either use the curved end or the straight end. My preference is for the straight end. And what we're doing is we're taking it from the center of the box here, and we're holding the explorer at 45 degrees to the long axis of the tooth, like so. And then what we're doing is we're sweeping from the center of the restoration here out toward the palatal. And as you can see there, what it does is two things. Firstly, it gives you a nice, neat, curved marginal ridge. And secondly, it pulls the composite resin towards that axial wall, like so. Then I'm going to do the same thing, starting at the center, 45-degree angle, and I'm moving out towards the facial or buccal. And you can see there, that's improving the adaptation there. So I've got a nicely adapted, more anatomical shape to my contact point there. Now, if you want to make that really, really smart, the second move is to use a brush, a number 1 brush. You just put that to one side for a moment. This is a standard number 1 brush, quite a narrow number 1 brush. This will work quite well, but another option is this contra angle brush here, which is also a number 1, but it's bent at an angle. This is much more useful for posterior work. So what I'm going to do here is I'm going to brush that using a modeling resin. This happens to be Brush and Sculpt from Cosmodent. And what this is a liquid resin which doesn't contain any HEMA, because HEMA will tend to discolor the tooth. Take a small amount of that, like so. That's too much, so what I'm going to do is just brush off the excess, like so. And then we're going to go to the tooth, and you can brush around the margin, like so. And that's going to improve the adaptation of the composite resin to the tooth. And it's also going to smooth out that mesial marginal ridge, so you have a lot less finishing to do. Once I've brush adapted that, I'm then going to pulse cure this restoration. So I'm just going to give it 1 to 3 seconds, 1 and 2 and 3. and then I can start to layer my occlusal portion and then finally cure that once I've layered the occlusal. Hopefully this is going to help you create more predictable Class 2 box closures that have fewer overhangs, have firmer proximal contacts, and have much less sensitivity and brown and white lines. Thank you very much for your attention.